Welcome back to Deep Dive Ortho, the space where we stop skimming the surface and get straight into the critical complexities of musculoskeletal care. In trauma, we often fixate, and rightly so, on restoring the bony anatomy of the distal radius. But the true architect of chronic pain and disability, well, it often lurks just adjacent, ready to undermine even the most meticulous surgical effort. I'm talking, of course, about the distal radial ulnar joint, the DRUJ. Our mission today is to pull this critical yet frequently underappreciated anatomical complex out of the shadows. We're going to examine the foundational anatomy, some of the most challenging traumatic patterns like Essex Lopresti and Galeazzi, and of course, modern management strategies. Guiding us through this is Prof. Mo Imam, a surgeon who has devoted significant time to understanding and restoring these intricate biomechanics. Thank you so much for being here.
It's a genuine pleasure. I think focusing on the DRUJ is what truly separates an acceptable outcome from a truly functional, pain-free one. It really is the joint of function.
Okay, let's unpack that straight away. We've all seen it. A distal radius fracture fixed perfectly on X-ray, yet the patient comes back with persistent pain, limited movement. Why is the DRUJ so notorious for this? Is it simply missed, or is there something inherent in its biomechanics that's, fighting our best efforts?
That's a great question because it's a bit of both. The core issue, fundamentally, is function. The DRUJ controls the entire mechanism of forearm rotation, pronation, and supination.
Which are essential for everything.
Absolutely. Turning a key dressing sport. Without that rotation, the hand can't interact effectively with the space around it. So when stability fails, a functional deficit is almost guaranteed. Now, as for why it gets missed, the distal radius is just visually dominant on the trauma scan. But the subtle instability often persists because, while restoring radial length and inclination does often indirectly reduce the DRUJ, that only really works if the soft tissue envelope, primarily the TFCC, is reasonably intact.
Or it heals well on its own.
Exactly. But if the DRUJ is independently injured, or if it stays unstable despite a perfect radius fixation, perhaps a big tear or soft tissue gets in the way, then you have to intervene directly. To ignore that is to guarantee chronic problems. We have to remember, you see, that we are restoring a dynamic pivot joint, not just a static bony alignment.
That distinction, dynamic pivot versus static alignment, that feels key. So let's revisit that foundational architecture. For our audience, we need to break down exactly how this joint is structured, focusing on those non-negotiable elements for stability.
Indeed. So starting with the bone, the articulation is between the convex ulnar head and the sigmoid notch. That's that shallow concavity on the ulnar border of the distal radius. The movement is complex. It's not just pure rotation.
There's translation involved, too.
Yes, the ulna has to translate volarly and dorsally during that arc of motion, and biomechanically, the joint is at its most stable in full supination.
Okay, and the soft tissues. This is where the real complexity lies, isn't it? We all say TFCC, but it's so much more than just a simple disc.
It's a complete dynamic complex.
Absolutely.
The triangular fibrocartilage complex is the primary intrinsic stabilizer. It attaches right into the fovea at the base of the ulnar styloid. Structurally, it includes the central articular disc, the meniscal homologue, and critically, the volar and dorsal radioulnar ligaments.
Those are the main stabilizers.
They are. Plus, it incorporates the origins of the ulnolinate and ulnotriquetral ligaments, and it forms the floor of the ECU tendon sheath. It's providing both support and a smooth gliding surface.
Now, the ligament tension and rotation, that's where things get really subtle. The research on the different fiber groups was crucial for understanding fixation, wasn't it? Remind us why understanding the deep fibers is so much more critical than the superficial layer when you're planning a repair.
That's right. That refers to the work that clarified the roles of those distinct groups. The superficial fibers are pretty much isometric through the range of motion. They function as the capsule, providing left critical restraint. The deep fibers, the ligamentum subcruentum, as it's sometimes known, are the true intrinsic stabilizers, and they tension reciprocally.
Meaning one tightens as the other loosens?
Exactly. The palmar, or volar deep fibers, are tightest in supination. They prevent dorsal translation of the ulnar head. They're a strong buttress. Conversely, the dorsal deep fibers are tightest in pronation, and they prevent volar subluxation. This reciprocal tensioning is vital. It means the joint is actively stabilized no matter where the forearm is rotated.
So if you lose one set,
you immediately get instability in the opposite rotational arc.
So if the common mechanism of injury involves wrist extension and pronation, we're likely challenging those volar deep fibers.
Precisely. In a forced pronation, the volar ligaments are what's preventing a dorsal subluxation. So if they fail, that's exactly where the instability will present itself.
And beyond this intrinsic core, what about the extrinsic and dynamic stability? Because muscle function must play a huge role here.
It certainly does. The primary external supports are the distal oblique bundle of the interosseous membrane, the IOM, the ECU subsheath, and the pronator quadratus muscle.
The IOM being critical for longitudinal stability.
Yes, which we'll get to with the high-energy injuries. But the pronator quadratus is particularly fascinating. Its deep head actively compresses the ulnar head into the sigmoid notch in pronation. It acts as an active, dynamic compressor. And this contributes significantly to stability, especially under load, like when you're gripping something.
That anatomical breakdown gives us the perfect blueprint for failure. So let's bring that into the clinic. The DRUJ is often the ghost in the machine, isn't it? The pain that's left after the main event. What clinical signs, what red flags should immediately make us suspicious?
The classic presentation is usually pain and a feeling of instability, which can be dramatically obvious in an acute dislocation. Chronically, patients complain of dorsal wrist pain, decreased grip strength, and a marked limitation in pronosupination.
And even a small loss of rotation can be devastating for function.
A 50% loss is catastrophic. During the exam, you're looking for mechanical symptoms, snapping, crepitus, pain on forced rotation with compression. For instability itself, 2 tests are key. The Ballotman test is widely seen as the most reliable. You're grasping the radius and ulna and translating the ulnar head to check for excessive movement or pain.
Compared to the other side, of course.
Always. And then there's the piano key test. It's a classic. You press down on a prominent ulnar head and it springs right back up when you release the pressure. Highly indicative of dorsal subluxation.
And the DRUJ rarely travels alone. What are the key associated injuries that should be screaming red flag at us?
It is a nexus of concurrent pathology. First, you have to aggressively look for ulnar styloid and distal ulnar fractures. A fracture through the base of the ulnar styloid is highly associated with the TFCC rupture.
Because that's the attachment site.
Exactly. Then, of course, TFCC tears themselves. Chronic issues can evolve into ulnar impaction syndrome, usually with positive ulnar variants. And finally, the big ones. The high-energy longitudinal patterns, Essex Lopresti and Galeazzi. If you see those, you automatically know there's massive soft tissue disruption.
Moving to imaging then. Standard x-rays can be quite misleading if they're not done perfectly, can't they?
They can. The AP view might show some widening, but a true lateral view must be taken with the forearm in neutral rotation.
Why is that so critical?
Because rotation can either mask or artificially create the appearance of subluxation. Radiographically, we define instability as the ulnar head being subluxed from the sigmoid notch by its full width in that neutral view. And you must always assess for proximal migration. Radial shortening of more than 5 millimeters is a major red flag for longitudinal instability.
So for the more subtle cases, what's the next step?
For subtle or chronic instability, a dynamic CT scan is invaluable. It's really the gold standard. You get sequential CT scans through a full arc of rotation. And if you see more than 50% translation compared to the uninjured side, that's definitively abnormal. For the soft tissues, specifically the TFCC, MRI is still crucial.
And if we do catch a purely ligamentous injury acutely, what's the non-operative plan? And how do we choose between supinating or pronating the cast?
Right, so if it's purely ligamentous, no bony fixation needed. The first line is closed reduction and immobilization for 4 weeks. The key, as you say, is the position of stability. It all goes back to those deep ligaments we discussed. For dorsal instability, you immobilize in supination.
Because that tightens the volar ligaments and pushes the ulnar head back into place.
Precisely. And for a volar instability, you do the opposite. Immobilize in pronation to tension the dorsal ligaments.
And what's the one thing to watch out for?
A critical caution. If you can't get a good closed reduction, you must immediately suspect tissue interposition. The most common culprit is the ECU tendon getting trapped. That necessitates an open procedure to clear the joint.
Okay, let's do a deeper dive on the TFCC itself. It's probably the most common soft tissue injury we see, but the spectrum is immense. We lean heavily on the Palmer classification. How does that framework help us differentiate traumatic from degenerative tears? And crucially, how does that guide management?
The Palmer classification is essential. It gives us a common language. It divides injuries into type I for traumatic and type 2 for degenerative or ulnocarpal impaction, tears. Type I traumatic injuries are categorized by location. peripheral detachment, which is the most common and repairable, central perforation, and radial avulsion.
And the key decision there is whether it's in the vascular periphery, which can be repaired, or the avascular center, which needs debriding.
Exactly. Type 2, on the other hand, details the progression of degeneration, usually driven by that positive ulnar variance. It moves through 5 stages, A to E, starts with simple thinning, then adds chondromalacia, then perforation, then lunotrochlear ligament disruption, and finally full DRUJ arthritis.
And that progression is so important because by the time you're at a IID or IIE, you're not just thinking out the disc anymore, are you?
Not at all. Urine management has shifted completely to dealing with instability and arthritis, often with osteotomies or salvage procedures.
So for those acute traumatic type I tears, when do we stick with non-operative management versus moving to a repair?
The initial management for all acute type I tears is typically non-operative, immobilization and acidasis. But if symptoms persist after 4 to 6 weeks, especially pain and instability, then we move to operative intervention.
And is there a consensus on open versus arthroscopic repair?
Well, operatively, we debride central tears and repair peripheral ones. And it's worth noting that modern evidence suggests really comparable long-term results for both arthroscopic and open peripheral repairs. The choice often comes down to surgeon comfort and the specific tear pattern. Arthroscopy does give you that brilliant view of any associated cartilage or ligament damage.
Right. And for the degenerative type 2 tears, where ulnar impaction is the main driver, the approach must be completely different.
Entirely different. With type 2 injuries, the management is all about offloading the ulnocarpal joint. You debride the TSCC care itself, of course, but then you have to address the ulnar length. There are 2 main options. An ulnar shortening osteotomy, or USO, is preferred if there's no DRUJ arthrosis. This reduces the relative length of the ulna and relieves the impaction.
And the other option is a wafer resection.
Yes, a wafer resection of the ulnar head.
That's a clever procedure. Can you elaborate on why preserving that specific TFCC attachment is so critical when you do that?
Absolutely. With a wafer, you're resecting a small amount of the dome of the ulnar head. But critically, you meticulously preserve the foveal and capsular insertion of the TFCC. By preserving that insertion, you maintain the crucial ulnocarpal support and ligament tension. It decompresses the joint without destabilizing it, provided the joint surfaces aren't too arthritic.
Let's quickly circle back to the ulnar styloid fractures. You flag them as a red flag. Does every fracture at the base need fixing?
No, it does not. And that's a key distinction. A base fracture suggests a high degree of initial displacement and is often associated with a TFCC rupture and instability. So the rule is this. If the DRUJ is clinically unstable after you fix the radius, then ORIF of the base fracture is indicated. Getting it to heal often helps restore tension to the TFCC.
But if the DRUJ is stable?
If the DRUJ is stable post-reduction, we generally leave the styloid alone. Non-unions are not typically associated with worse long-term outcomes unless they become symptomatic. It's the DRUJ instability that drives the decision, not the fracture itself.
Okay, let's move on to the really challenging high-energy injuries, Galeazzi and Essex-Lopresti. These are notorious for being missed. What makes them so unstable?
The instability in these injuries comes down to a total failure of the central column. And the key to that column is the interosseous membrane, the IOM. We must think of the IOM not just as a sheath, but as the primary load transfer mechanism. If the radial head is compromised, the IOM is responsible for about 70% of forearm stiffness and transmits a staggering 90% of the axial load.
And it's the central band that's the crucial part.
It's the strongest and most critical component for longitudinal stability. Once you disrupt that, the forearm just ceases to function as a rigid column. You get proximal migration and collapse.
Let's start with the Galeazzi, the fracture of necessity. Could you clarify its definition and talk about those intense deforming forces?
A Galeazzi is a fracture of the distal third of the radius shaft with a concomitant DRUJ dislocation. It's called the fracture of necessity in adults because it is just inherently unstable. You have powerful muscular forces acting on that short distal fragment. The abductor pollicis longus, extensor pollicis brevis, brachioradialis, they all pull it proximally, and the pronator quadratus exerts a rotational force.
So you can't just cast it.
No, the forces will always overcome it. The DRUJ will just redislocate.
So the gold standard for adults is ORIF. What's the single non-negotiable step in that procedure?
The meticulous restoration of the anatomical radial bow and radial length. You have to get that perfect. We typically use a Voller-Henry approach. If the radius is shortened or malrotated, the sigmoid notch is displaced, and the DRUJ simply cannot be congruently reduced. And once the radius is fixed, you must immediately assess the DRUJ dynamically.
And if it's still unstable?
Options include fixing a large ulnar styloid fragment, repairing the TSCC, or, if needed, transfixing the DRUJ with K-wires. And that's usually done in supination for 6 weeks to hold the reduction.
Now for the Essex Lopresti, the triad of massive instability connecting the wrist, forearm, and elbow. Why is this one so difficult to diagnose?
The Essex Lopresti is a radial head fracture, a rupture of the entire IOM, and a DRUJ dislocation. The challenge is immense because the radial head fracture can be subtle, and the IOM rupture is completely invisible on a standard X-ray. It requires a very high index of suspicion, especially in high-energy trauma with a radial head injury.
And if you miss it?
The consequences are devastating. You get progressive, unchecked proximal migration of the radius. This leads to chronic elbow pain from radiocapitellar impingement and severe ulnar wrist pain from ulnocarpal abutment.
So if X-rays aren't enough, how do you prove IOM disruption?
We rely on dynamic assessment. The classic test is the radius pull test. You apply about 20 pounds of axial traction to the proximal radius. If you see 3 millimeters or more of migration, that's a positive test. It proves the central column has failed.
Given the consequences, what are the management principles, both for the acute injury and for that delayed chronic presentation?
Acute ELI requires addressing all 3 parts. First, the radial head. ORIF if possible, but often it needs replacement. We advocate for titanium radial heads over silicone in active patients.
Why titanium specifically?
Well, historically there were concerns about silicone's failure mode, particulate degeneration leading to synovitis. Titanium provides that mechanical stability without the same biocompatibility risk. Second, the DRUJ must be immobilized or pinned. Third, and this is more controversial, many now advocate for acute IOM reconstruction. There's a strong concern it just won't heal properly on its own.
And that brings us to the most technically demanding part, IOM reconstruction. How do you choose between, say, a tightrope and a tendon graft?
It's a complex decision. Biomechanical studies show none of the current techniques fully restore the native stiffness of the central band, which is incredibly strong, but they do significantly improve load sharing. A tightrope tenodesis is a strong acute stabilization method that's technically simpler. It avoids donor site morbidity, but some worry about long-term stability without a biological structure.
And the tendon grafts.
Tendon grafts, autograft, or allograft, aim to recreate that anatomical diagonal line of the central band. We often favor techniques that minimize remote donor site morbidity, like the pronator rerouting autograft.
That's a fantastic example of using local tissue intelligently. Could you walk us through the technical steps of that reconstruction? Why the 4mm distraction?
Certainly. It's a multi-step procedure. First, you manage the radial head, replace it, making sure not to overstuff the joint. Second, you harvest the graft. The pronator teres is trached back. The muscle is transected proximally, very carefully, protecting the median nerve, and the distal insertion on the radius is left intact. In chronic cases, you do an ulnar shortening osteotomy first to manage the abutment, but then comes the most critical step, the distraction.
This is the 4mm part.
Yes. You use a distractor to distract the radius, about 4 millimeters at the radiocapitellar joint. This is crucial because it restores the anatomical length and tension to the whole forearm column before you fix the graft.
And then the graft fixation.
The prepared pronator graft is rerouted in a distal oblique direction, mimicking the central band's path. It's then secured to the ulna with the wrist held in neutral rotation.
Why neutral?
We fix it in neutral rather than pronation or supination because this minimizes the tension on the graft throughout the entire rotational arc. It allows for a much more balanced rehabilitation.
That level of reconstruction really speaks to how critical forearm stability is. But for high-demand patients, a subjective test isn't really enough, is it? We need quantitative tools.
The reliance on subjective tests is a major limitation. The field is moving towards quantitative assessment, and one really promising method is force monitor ultrasonography. It's incredibly objective. It uses an ultrasonic transducer attached to a compression apparatus to measure radial CNR displacement during a controlled, repeatable force.
And that gives you a number.
It gives you a displacement to force ratio in millimeters per Newton. It's a robust, objective indicator of instability. It lets you track recovery and compare outcomes quantitatively.
Let's apply that to a real-world example. There's some fascinating research looking at elite wheelchair basketball athletes. What did that study reveal?
This was a compelling study. It's a high-stakes group because their upper limbs are under extreme repetitive loading. They found TFCC injuries in nearly 39% of the wrists in this cohort. They found two key things. First, in the wrists that were already injured, they showed significantly restricted ulnar deviation compared to intact wrists.
That makes sense. Injury leads to restriction. But the second finding in the intact wrists is where the implications for prevention really emerge.
Absolutely, this is the critical correlation. In the wrists that were still intact, they found a strong negative correlation between DRUJ instability, a higher displacement to force ratio, and several clinical functions, specifically grip strength and upper arm and forearm circumference.
Let's unpack that. A negative correlation means.
It implies that the athletes with greater upper arm and forearm strength, objectively measured, had significantly greater DRUJ stability in their uninjured wrists.
Wow, so that's powerful evidence that the dynamic stabilizers, the muscles, are not just secondary supports. They are actively providing enough compression to maintain DRUJ integrity.
Exactly. Even under extreme cyclic loading, the clinical implication is profound. It suggests that maintaining and strengthening these external support mechanisms directly contributes to DRUJ stability.
So for high-demand groups, strengthening could be a practical, effective way to prevent these injuries in the first place.
That's the urgent question it raises. It highlights the role of the muscle envelope as a stability factor that we can actually influence.
That's a fantastic forward-looking perspective. Now let's pivot to the last resort solutions for those chronic, painful cases where reconstruction is no longer on the table. What are the modern salvage procedures?
When the DRUJ is chronically unstable or arthrotic, our options fall into three main categories: excision, fusion, and replacement. Starting with excision, the classic Darac procedure resection of the distal ulna is now really reserved for low-demand, elderly patients.
Because of the unstable ulnar stump?
Yes, that dynamic radioulnar convergence is a significant risk in active patients. The stump can impinge painfully against the radius. A refinement is the hemiresection arthroplasty, where you resect only the diseased part of the ulnar head while preserving that critical TFCC insertion.
And the alternative to resection, the Sauvé-Capangé, which preserves the ulnocarpal ligaments.
Precisely. The Sauvé-Capangé involves a DRUJ fusion, so the radius and ulna are fixed distally, coupled with the creation of a proximal ulnar neck pseudoarthrosis. Its major advantage is preserving that ulnocarpal support. The wrist itself is stable, and rotation occurs at the pseudoarthrosis site. It's a robust option for the high-demand individual.
And finally, replacement.
Yes, ulnar head prosthetic replacement is viable, but many designs require a competent TFCC. If both sides of the joint are affected, a total joint replacement is an option. The ultimate salvage, of course, is the creation of a one-bone forearm, but that sacrifices all rotation.
Let's close the loop then by detailing the post-op journey. For a major reconstruction, the rehab protocol is paramount. What does a phased recovery look like?
It's highly structured, focused on initial protection, then progressive reintroduction of movement, usually over 4 phases. Phase 1 is maximum protective, from week 0 to 6. The goal is strict immobilization and edema control. The key orthosis is the Munster splint.
And why the Munster specifically? Why not just a short arm split?
We use the Munster because it fixes the elbow at 90 degrees. This prevents the patient from generating large amounts of rotational torque through the forearm, which could damage the healing graft. It's worn full-time.
And once that initial protection phase is over, how do you carefully reintroduce movement?
That brings us to phase 2, from week 6 to 12. The goal shifts to restoring pain-free active range of motion. The patient transitions to a wrist-hand orthosis. We initiate gentle wrist and forearm AROM, often 6 times a day for short sessions. Gentle passive range of motion might start cautiously around the 8-week mark. The key word is gentle.
And then strengthening begins in phase 3.
Yes, from weeks 12 to 16. The goal is to restore functional ROM and introduce isotonic strengthening. We continue a ROM and begin cautious PROM, but critically, the therapist must secure the forearm proximally to avoid inducing any torsional load on the healing DRUJ.
What specific strengthening exercises are you starting there?
We begin with isometrics for all the wrist and forearm muscles, then progress to isotonics using things like TheraBand or light putty. We start focusing on that dynamic stability we talked about.
Closed chain exercises first.
Exactly. Rhythmic stabilization while leaning on a table, progressing to open chain work. And we ramp up proximal strengthening too. Finally, phase 4, from 16 weeks onwards, is about progressing strength and returning to function. We begin aggressive PROM, targeting 85% of pre-surgical ROM by 6 months. For high-demand patients, a work conditioning program may be appropriate.
This detailed phased approach really underscores the high stakes of this joint's rehabilitation. We've covered the indispensable role of the IOM and TFCC, the red flags for Galeazzi and Essex Lopresti injuries, and the nuanced approach to reconstruction and recovery. If you found this deep dive valuable, please do take a moment to rate and share Deep Dive Ortho with your orthopedic colleagues. Looking ahead and thinking back to that fascinating data on the wheelchair athletes, that strong link between muscle strength and DRUJ stability, what final provocative thought should we leave our audience with?
That data is key. If we accept that dynamic external support strong musculature correlates with higher DRUJ stability, it raises a significant question for our patients. When we're addressing chronic instability, how might we adjust preoperative or immediate postoperative conditioning protocols for the shoulder, arm, and forearm? Could dedicated muscle hypertrophy and strength training enhance that crucial dynamic stability, perhaps compensating for some residual ligament laxity and improving the long-term success of our complex reconstructions? That integration of biomechanics and prophylactic strengthening, I believe, is where the next evolution of forearm stabilization will surely lie.